As-salatu as-salamu alayka ala rasulil kareem, Sayyidina wa Nabiyyina Maulana Muhammad wa ala alihi wa ashabihi ajma'een. Inna Allaha wa malaikatahu yusalluna ala nabi. Ya ayyuhallazina amanu sallu alayhi wa sallimu taslima. Allahumma salli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad wa barik wa sallim. On behalf of the Islamic Medical Association Durban branch, I'd like to welcome you in the name of Allah Ta'ala, our creator, sustainer, provider, bestower of numerous bounties, not forgetting bestower of our wives and our children. Alhamdulillah. I am Dr. Solwa from the Durban branch, facilitating this meeting for you this evening. For those who have difficulty in conceiving while in the beautiful bond of marriage, our experts are here to address these challenges of infertility, keeping in mind the Islamic injunctions from the Quran and Hadith. The Islamic Medical Association acknowledges the very kind sponsorship from Delphrem Pharmaceuticals, leaders in fertility treatment in South Africa. Please note some home-taking rules. This Zoom meeting is being recorded, and the recording would be available to you maybe in a week's time. The meeting is accredited for 1 clinical and 1 ethical point by the College of Medicine. You may post questions in the comments box or the chat box. These will be directed to the respective speakers at the end of the presentations. I would advise you to please mute yourselves so that you do not interrupt the meeting, and also do not put your videos on. You need to give us your name and your HPCA number, which I see many of you all have already done, so that the CPD certificates can be posted or emailed to you. The program for this evening is our first speaker will be Mr. Francois Freire, who is a director and pharmacist at Delphrem Pharmaceuticals in Centurion, and he will address us for 10 minutes. Francois, you may go ahead.
Thank you, Dr. Solwa and Dr. Natsay, for the opportunity to sponsor the IMASA fertility meeting. And also to tell you a little bit more about Delphrem Pharmaceuticals. We have a family-owned business, and we started in 2006, and we decided to be a fertility and focus only on fertility. We cannot compete with all the generic companies. So we supply really specialized and niche products to the fertility clinic itself. But we also sell fertility-related products to the medical profession as well. For a South African company, we're also research-driven, and we basically focused at the moment on andrology, and of course the role of inositols in different diseases, but we also, but in this case, in fertility. Our goal was basically from the start to give each couple that's struggling with infertility the opportunity to have a child. We're still very far from that, but we'll keep on working on that. Just some products that we sell to the medical profession. On the male side, we have a product called Spermicide, and the main objective is to reduce the oxidant load and to rectify the vitamin and mineral shortages to produce normal sperm. Now, today there's a lot of products available on the South African market, and they put in a lot of antioxidants, but that can be also bad for getting the patient pregnant, because the sperm will require some oxidant to fertilize the egg. And if you give too many antioxidants, then it will improve the sperm parameters, but it will have a negative on the pregnancy itself, or the patient getting pregnant. With the Spermicide, one capsule twice daily, and you have to treat for at least 3 months at the end of the day, and it's packaged in it contains 60 capsules. On the female side, we sell quite a lot of products. The first one is basically for controlled ovarian hyperstimulation, which is Merinol, that's an HMG, and Fostimon, that is a follicle stimulating hormone. Then we're also working very closely with a company that doing compounding to provide products that's not freely available in South Africa or that is not registered here. Now the advantage of the compounding product is that you don't have to apply for Section 21, and it's done on a prescription basis. And for that we supply natural progesterone, it's specifically for the luteal phase where the oral or vaginal products does not work or increase the concentration high enough. Then also GnRH agonists as well as antagonists, which can be provided in a single or in a pen system, and then HCG for triggering as well, again in a single or pen system. And if you have any product that you want to compound, please contact us, and we can liaise with the company that is doing that. Now, although bacterial vaginosis is not may not have an effect on infertility itself, we know that once a woman is pregnant and she's got bacterial vaginosis, she may lose the baby quite early during pregnancy. And that is why we say you have to treat the STDs, but you also have to make sure that there's no bacterial vaginosis. And as you know, the prevalence of BV is quite high in South Africa. For that, we have a product called Fertility, and it's an applicator with 3 ml solution or gel, and you just give the contents of one applicator per vagina stack, and that can also be done in the practice itself. If one look at primary dysmenorrhea, it's not it doesn't really have an effect on infertility, but the problem is that most of the females utilize a non-steroidal anti-inflammatory product to address the pain, but it basically have an effect. First is you've got effect on the gut, as you all know, but secondly, it can actually postpone ovulation, and that basically takes when the embryo is ready, it's not synchronized anymore, so the endometrium might be over the period that it will accept the embryo for implantation. So it is better to use a product that don't have any effect on ovulation. And that product is called Desmeno capsules, 100 milligram. And you basically take 1 capsule 3 times a day daily, and you start 3 days before menstruation and continue until the end of menstruation. We're looking at secondary dysmenorrhea later. These studies now being performed, and as you know, with secondary dysmenorrhea, all the products that you utilize are hormonal based, and you cannot utilize it if they want to conceive. We also launched the first inositol in the South African market for the treatment of infertility. And although there's 9 different inositols, we only concentrate basically on 2 for the fertility market. And that's myoinositol, which is an integral part of the secondary messenger transport system to carry the hormonal message across the cell membrane. And very important, you require at least 4 gram myoinositol powder per day. And there's a lot of generic companies that is putting a lot or that launch product with less than 4 grams per day and telling that it's got exactly the same working or that's working. And that is not the case. You need at least 4 gram myoinositol. Dechiroinositol responsibility is to turn the extra glucose entering the cell into glycogen, and you require a lot less, and the ratio basically is 1:40 of the myo-inositol. Now, where does it play an important role in infertility? More than 99% of the inositols in the follicle must be myo-inositol. And for example, with PCOS, the myo-inositol dechiral ratio in the follicles are totally disrupted, and it's about 50-50. And that is why the follicle will not develop properly. And to treat the patient with PCOS with or without metabolic syndrome is a product called Inofolic. And the generic of that will be Myoflate. And the whole thing is to rectify the insulin as well as the female hormones and the myo-inositol and dechiral-inositol in the follicle imbalances to ensure development of good quality oocytes, because that is what we're all aiming for. Now, one has to take one sachet twice daily, and for infertility, it's important to take it twice daily and not as a single dose per day. The big advantage of using Inofolic and Myoflate is that you don't have to monitor the patient compared to clomiphene. The other thing is we know that PCOS patients have a lot of symptoms and long-term complications. And to try and prevent that is we launched a product called Picositol. It contains the 4 gram myo-inositol and 100 milligram of dechiral-inositol, but also the vitamins and minerals that's associated with PCOS. And the big advantage is that the patient only have to take one sachet basically in the morning. Then another, if you've got Hashimoto's disease, there's a chance that it have an impact on the infertility. And we launched a product called MyThyrox tablets for that, which contains 600 milligram of myo-inositol and 60 milligram of selenium. And the whole reason for that is most of the time your thyroid stimulating hormone are either very high or low, and then because of the fact that the secondary messenger system in the thyroid is not working properly. And the selenium is basically there to prevent the thyroid damage caused by the oxidant, which then produces the antibodies at the end of the day. And for that, one can give one tablet in the morning. For a patient with metabolic syndrome, most of the time metformin is prescribed, but some patients cannot take metformin, and some do not cannot take the side effects that's part of that. And for that, medicine X can be prescribed. It contains myo-inositol and the dechiral-inositol, and specifically to address the insulin hormonal imbalance with causing metabolic syndrome or syndrome X. And it can also be given with metformin if required. And then, of course, to make it a little bit more cost effective, we've got a Delphin family starter pack that contains Inofolic and spermide-proof, so for male and female, and then ovulation as well as a pregnancy test. Now, on the research side, if one look at WHO concerning sperm, is they're only looking at sperm that did not enter the uterus as yet. So what we're looking at is to see what happened to the sperm, because that's just as important to look at the sperm if they can fertilize the egg or not. And the first part, and we developed a diagnostic kit for that, that is first in the world. And we measure basically if the sperm will be able to capacitate or hyperactivate. Now, the main thing is normally the sperm have to swim straight, but when it capacitate and hyperactivate, it have to go from straight into a star formation, and it really looked like a star because they're swimming around to find the oocyte. And then it also has to double its speed, and the normal eye cannot see that. So you require a sperm class analyzer that will be able to track each and every sperm. Now, there's 3 systems basically available that you can do sperm analysis to see if the sperm will capacitate or upactivate, and that is at Cape Fertility Clinic, and then Pretoria Fertility, as well as Lancet Andrology Department in Pretoria. The other product that we developed that is also brand new in the world is HT Sperm Wash, and it is basically indicated for normal sperm, but if the motility is low, you cannot really utilize. And when we wash the wash the sperm in the HT Sperm Wash, it not only improves the motility as well as the sperm's ability to capacitate and hyperactivate. So sperm that you would have rejected in the past would be now suitable either for IUI or normal IVF. So yeah, so thank you for the opportunity. So if you want more information, please visit Delfrang's website at www.delfrang.co.za, or you can email us at info@delfrang.co.za. Thank you for the opportunity and enjoy the rest of the presentations. Thank you.
Thank you very much, Francois. Beautiful presentation. A lot of catching up to do, certainly, and a lot of research. And what's amazing, it's a family business. That's great. And we really pray that you go from strength to strength. Thank you very much, Francois. Thanks a lot. Okay, we go ahead with the program for this evening. And we've got 2 speakers this evening, right? And both are experts in their fields. The first is Dr. Razak Dansey. He's a gynecologist, graduated in KwaZulu-Natal. That was the main reason why I got him. He specialized in ONG at the University of Cape Town. He did his subspecialty at the Reproductive Medicine and Fertility Training Center at Glasgow Royal Infirmary. He's a part-time medical consultant at UCT, a fellow of the College of ONG in South Africa, and a member of the South African Society of Reproductive Medicine and Gynecology. He is also a member of the European Society of Reproduction and Embryology. He's going to speak to us on an approach to an infertile couple and the management thereof. We look forward to listening to Dr. Razak this evening. Dr. Razak. Dr. Razak, can you hear us? Can't seem to get hold of Dr. Razak. Dr. Razak, can you hear me?
Yes, Dr.
Okay.
Mohammed, I can hear you.
Okay. Take your time, but you are on. You can start your presentation.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم صل على سيدنا محمد وعلى آل سيدنا محمد وبارك وسلم. The talk outline, I'm going to focus on preconception counseling, male factor infertility, polycystic ovarian syndrome, and female fertility preservation. The World Health Organization defines reproductive health as complete physical, mental, and social well-being. People affected by infertility have higher rates of anxiety, depression, suicide, divorce, partner violence, and societal stigma. Infertility is defined as 12 months of unprotected time intercourse around the ovulation period. when it comes to time around the ovulation period, this is easy for women that have 28, 30-day cycles. We know that they will ovulate between day 12 up to day 16 of the cycle. Women that have longer cycle from 35 to 40 days, they will probably ovulate, but it will be between day 22 to day 24 of the cycle. And it is defined for women less than 35 years as 12 months, and for women over 35 years as 6 months.
Dr. Dansey, can I just remind you to share your screen, please?
Sorry. How do I go back now?
Dr. Dansey, the share screen button at the bottom, please.
I've sort of lost it.
The green one.
I'm not sort of there.
You've got to open your PowerPoint on the rest of your documents.
I can't see anything here.
Okay, Dr. Dansey, did you click on the share screen button at the bottom, the green one we did earlier?
No, I actually didn't.
Okay, please.
Okay.
Once you do that, then it will open up your PowerPoint.
Where are we now? Come on.
Can you see the share screen button?
And I can't see it at all.
Okay, what view do you have on the top? Do you have the speaker view or gallery view?
No, I don't have any view on top.
Okay.
I think perhaps just put your finger on the screen, maybe the icons will come up.
No, it's not coming up. I think I need to close and actually log on again.
Okay, you can try that.
You can just do that now. Okay. Okay. Okay, share screen. There we go.
Yes, that's right.
Okay. Okay. From the beginning.
And then you'll have to, I think your screen has been minimized on the top. No, the other one, the one next to that.
Hi. Okay, is it better now?
Okay, the one, see from the beginning? Yeah, now click on from the beginning. The
From the beginning?
slideshow.
Okay. Yeah.
Okay, but the only thing is okay, press escape just once, please.
Jade, press.
Okay, no, it's fine. You can go ahead. It's okay. We can see your screen.
Okay. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. I'm going to focus my talk on preconception counseling, male factor fertility, polycystic ovarian syndrome, and female fertility preservation. The World Health Organization defines reproductive health as complete physical, mental, and social well-being. People affected by infertility have higher rates of depression, anxiety, suicide, divorce, partner violence, and societal stigma. Infertility is defined as 12 months of unprotected time intercourse around the ovulation period. This is easy for women that have 28, 30-day cycles. They would normally ovulate between day 12 to day 16 of the cycle. Women that have longer cycle between 35 to 40 days, they will most likely ovulate intermittently between day 22 to day 24 of the cycles. So for women under 35 years, this is defined as 12 months, and for women over 35 years, this is defined as 6 months. And this definition is based on the cumulative probability of the pregnancy. 50% will conceive within the first 3 months, 72% within 6 months, and 85% within 12 months. Infertility affects 1 in 6 couples. And we have noticed over the years that the birth rate among US women have dropped from 106 per 1,000 women per year during 1950 to 63 per 1,000 women per year during 2015. And I suspect this drop in rate has been across Europe as well. And part of the reasons for this drop in conception or birth rate has been this is due to later marriage, improvement in contraception, access to family planning, more women pursuing studies, careers, and rising rates in obesity and decline in sperm counts. Also important to note that birth rate has shifted from by age. Less women are giving birth between the age of 15 to 29, and more women are giving birth from the age of 30 to 42 onwards. ART or assisted reproductive techniques have been developed to assist infertile couples, but access to these services has remained a challenge due to lack of awareness, lack of availability of treatment, and prohibitive cost. The causes of infertility is divided into the following. Male factor accounts for 35%, ovulatory factors 15%, tubal factors 35%, unexplained infertility 10%, and the others of 5%. When it comes to unexplained infertility, this means that as far as the male is concerned, he has a normal semen analysis, and as far as the female is concerned, she has her ovarian reserve is good. She has regular ovulatory cycles, no tubal problem, and the outward tract, the uterus, endometrium, and cervix is normal. Also important to note that the cause of infertility varies in different geographical areas. And in Africa, the tubal factor infertility is sort of common cause of infertility that we see. And part of this is probably related to the high prevalence of pelvic inflammatory disease. When it comes to preconception counseling, I think it is important all women that visit gynecologists as a routine or women that are accessing general practitioners. It is also important to ask whether couples are planning pregnancy or not. So women that are planning pregnancy, they should maintain a healthy lifestyle, and as well as prevent any sexually transmitted diseases. They should maintain a healthy body weight, because obesity affects both male and female infertility. Important to bring the attention that they should avoid smoking, use of illicit drugs, anabolic steroids, excess caffeine intake, and environmental occupational toxins. What we do know from a lot of studies have shown that people that smoke, it can take them twice as long to conceive. We know that anabolic steroids can have a detrimental effect on the chromosomes and genes. Excess caffeine can also reduce monthly conception rate. Important that women should start on folic acid. The minimum is 400 micrograms. and folic acid should start at least 2 to 3 months before conception, and this should be taken until 14 weeks of conception. Women might need a higher dose of 5 milligrams. Those are at risk of neural tube defects, previous history of neural tube defects, anti-epileptic medication, methotrexate, diabetics, and obesity. Important to actually screen for rubella immunity as well. And those women that are not immune to rubella, they should be vaccinated first. And after vaccine, they should wait a period of 6 to 8 weeks before they plan a pregnancy. When it comes to screening of women, those that should be immediately referred are women over 38 years old, those with menstrual irregularities, that is cycles less than 21 days and more than 35 days, history of previous pelvic surgery for fibroids, myomectomy, surgery for endometriosis, ectopic pregnancies, and tubal ligations. History of suspected endometriosis, family history of premature ovarian insufficiency, and woman that has been exposed to radiochemotherapy for cancer treatment. Male infertility. Male infertility accounts for 30% of infertility, and it is important that examination of the male, both couples should be examined and counseled at the same time. Even if so we start off from the history and on examination from the male aspect, duration infertility, has there been history of previous infertility, timing of puberty, whether there has been precocious or delayed puberty, history of any testicular trauma or testicular torsion. Testicular trauma torsion can cause atrophy of the testes, and it can also cause anti-sperm antibodies. Also surgery for undescended testes and inguinal hernia repairs. Important to inquire about history of drug abuse, history of smoking, marijuana, recreational drugs, and anabolic steroids. We know that as far as smoking is concerned, smoking can affect the sperm count, motility, and quality as well. Chronic alcohol abuse can decrease testosterone levels. Recreational drugs, anabolic steroids can cause DNA damage of the sperm. History of mum otitis can also cause a problem with sperm, and exposure to environmental toxins, especially lead and pesticides. A lot of the pesticides have estrogenic effects as well. And important to screen and inquire for sexually transmitted diseases. From the medical aspect, history of diabetes is important, because diabetes can cause autonomic and neurogenic impotence. Chronic respiratory disease, like cystic fibrosis, is associated with bilateral absence of the vas deferens. The vas deferens is a tubal structure that transports sperms from the epididymis to the urethra. Obesity also has a direct effect as well. From the sickle cell disease, it's not the sickle cell disease itself, but it is a multiple transfusions which the patient receive for sickle cell disease, and the increase in the hemosiderin and iron concentrations can cause obstruction of the vas deferens. The examination of the male should focus on the physical examination, normal development, sexual characteristics, bilateral presence of the testes, size and volume of the testes. If the testes are small, it alerts us to the possibility of testicular failure. The semen analysis. The semen analysis is based on the WHO 2010 criteria. This is a standard or way of doing it. And before the semen analysis, abstain for 2 to 3 days. The specimen can either be produced at home or it can be done at the lab. Important is that from the time the specimen was produced, it should be kept at body temperature and reach the lab within 1 hour. For men that have difficulty producing the produced sperm sample, we have special condoms as well that can be used during intercourse. As long as, and these are put in a special container and they have to reach the lab within 1 hour. The normal volume is 1.5 to 2 moles. 1.5 to 5 moles. If the sperm volume is less than 1 mole, there's a possibility of retrograde ejaculation. The sperm count should be more than 15 million. The progressive mortality should be more than 32%, and the total mortality more than 42%. And the morphology of the sperm morphology should be more than 4%. It is important that the morphology refers to the shape of the sperm head, and this is where the DNA and the genetic information is stored. The sperm morphology has been developed by Professor Kruger, and we refer to it as the strict criteria. The morphology of 0 to 4% is classified as poor prognosis in terms of fertilization rates, and good prognosis of between 5 to 14%. Small volumes of sperm is due to retrograde ejaculation or ductal obstruction, and retrograde ejaculation is confirmed by the presence of sperm in a post-ejaculate urine. Patients with azoospermic samples, the semen should be centrifuged and evaluated under the microscope to make sure that where the sperms are present or not. In men with azoospermic sperm samples, we go back to the history to find out in terms of have they had any infections, any previous surgical trauma to the testes, etc. Men with azoospermia, the sperm sample should be repeated after 2 months, and the reason for that being that it takes from immature spermatozoa to produce mature spermatozoa takes about 60 to 72 days to make 1 cycle of sperm. During surgery for varicocele is indicated if they have a palpable varicocele with abnormal sperm numbers. As long as it's female, there's no female factor. Treatment of male factor infertility. When there are borderline semen parameters, when the sperm count is just within 15 million, mortality just about 30%, and the morphology 2 to 4%. These patients are subjected to intrauterine insemination. And the important part of this is the sperm wash or the harvest that is prepared afterwards. It should be at least 1 million sperm per mil. And we advocate ovulation induction so that by ovulation induction, at least more than one follicle will be actually produced. Men who are azoospermic with normal size testes and a normal hormonal profile. That means the testosterone is normal, FSH levels are normal. This is most likely due to obstructive azoospermia. There is an obstruction of the vas deferens. The treatment visits would be testicular biopsy to retrieve sperms. These sperms actually frozen, and this can be used during in vitro fertilization with intracytoplasmic sperm injection. All testicular biopsy samples are actually frozen, which will be used for the next time again, and it's very seldom that the testicular biopsy has to be repeated again. Men with azoospermia and small testes and elevated FSH, this is due to testicular failure, and the role of a biopsy is to confirm germ cell aplasia or Sertoli cell syndrome. Patients with germ cell aplasia or Sertoli cell syndrome, they will have small to normal size testes, but the FSH levels will be high. The next topic I'm going to talk about is polycystic ovarian syndrome. Polycystic ovarian syndrome is commonest economous endocrinopathy, affecting 8 to 13% of women of reproductive age. It's very important to note, depends on what the literature we read as well. The incidence of polycystic ovaries on ultrasound is about 20 to 30%, but not everybody has a polycystic ovarian syndrome. According to the Rotterdam criteria, we need 2 of the following 3. Number 1, menstrual irregularity. That is menstrual cycles of less than 21 days or more than 35 days, or less than 8 cycles per year, and either biochemical or clinical features of hyperandrogenism. The biochemical features would be increase in testosterone, free testosterone, and increase in DHEAS, and the clinical features would be acne, facial hair, and male pattern, and male facial hair, and male pattern of hair distribution. Then on the ultrasound diagnosis, the polysignal ultrasound, there should be at least 20 or more of small follicles between 2 and 9 millimeters present on at least one ovary. That is 20 or 30 more 2 to 9 millimeter follicles of 2 to 9 millimeter in size on at least one ovary, or the ovarian volume should be more than 10 mils. For the adolescents, the diagnosis of they call it oligomenorrhea and hyperandrogenism is actually required, and the diagnosis is usually made 2 years after the onset of 2 years after the onset of menarche. Ultrasound is not recommended for the diagnosis of PCO because the follicles are not completely developed at this stage. Important in the diagnosis of polycystic ovarian syndrome is to exclude the different diagnosis: hyperprolactinemia, thyroid dysfunction, Cushing's syndrome, and congenital adrenal hyperplasia and androgen secreting tumors. Polycystic ovaries is also associated with a wide range of medical illnesses. Because of the chronic anovulation resulting in unopposed estrogen levels, this causes abnormal uterine bleeding and endometrial hyperplasia. This causes a 3 to 4-fold increase of endometrial cancer. And this is the importance of regular withdrawal of progesterone to induce bleeding. Polycystic ovaries is also associated with increased miscarriages during gestational diabetes and gestational hypertension. The other important thing is the metabolic syndrome. This is associated in women with obesity, abdominal obesity of more than 88 millimeters in circumference, hypertension, dyslipidemia, impaired glucose tolerance, type 2 diabetes, cardiovascular disease, and sleep apnea. These patients also have an increased risk of eating disorders, body image distress, and a 5-fold increase of anxiety and depression. There is no standard cure for polycystic ovarian syndrome, and the actual management is based on what the patient presents for. It's either for fertility treatment, acne or hirsutism, and obesity. And important to bear in mind that the polycystic ovary does not disappear on ultrasound. The features are actually always going to be the same, because often patients come and ask, doctor, I'm going to check whether my polycystic ovaries is actually getting better or not. From the management of infertility, the cause of infertility is due to chronic anovulation. And the first line of management is actually weight loss. And important to actually bear in mind that as a modest weight loss of 2 to 5% can actually restore ovulatory functions. Weight loss is not very easy. It is there's lots of other issues with weight loss in terms of the mechanism between the brain and the gut as well. There's no specific PCO diet. Important thing is a healthy choice of food, a balanced diet, and reduced calorie intake, and regular exercise. As again, stressing weight loss, importance is in fact the modest decrease in weight loss will actually help as well. And this is a long-term goal. It's not only from the fertility point of view, but weight loss is so important in terms of delaying or preventing onset of diabetes, high blood pressure, etc. From the ovulation induction point of view, letrozole is the first line for ovulation induction. The advantage of letrozole is that we have higher ovulation rates. Letrozole is unlikely to cause multiple pregnancies because women will ovulate producing one follicle most of the time, compared to clomiphene citrate. And the advantage of letrozole, it doesn't affect the endometrial lining. Metformin is actually recommended for metformin recommended for women with a BMI of over 30. This will improve ovulation rates, help with weight loss, insulin resistance, and also reduce the chances of miscarriage as well as gestational diabetes and increases the live birth rates. from the management, the oral contraceptive pill is the first line of management for acne and hirsutism. There's no specific brand recommended, but those pills that contain cypertron acetate, they have advantage in terms of they block the androgen receptors on the skin as well. The last topic is female fertility preservation. Egg freezing has always been available for women at risk of infertility due to affecting ovaries due to radiochemotherapy for cancer treatment. And as diagnosis and cancer treatment has actually improved, we found lots of young women in reproductive years. We have problems with premature ovarian insufficiency or premature ovarian failure. The problem is women are born with a non-regenerable pool of oocytes, 6 to 7 million at the time when they're 20 years gestation. This drops to 2 to 3 million at birth and 300 to 400,000 at the time of puberty. Egg freezing has become an option for women with age-related infertility, or those who are delaying the childbearing for career reasons, or the woman without a partner. So these are what they call social fertility preservation. As we know that there's a sharp decrease in fertility rate from the age of 35. The anti-Mullerian hormone is a glycoprotein produced by the primary, preantral, and small follicles in the ovary. It is a key regulator of folliculogenesis, and it is the most important biomarker that we have to measure the quantitative ovarian reserve, and it is constant throughout the menstrual cycle. The likelihood of achieving a pregnancy after egg thawing depends on the age and the number of oocytes that were actually frozen. For those women who froze before the age of 35, with 24 or more eggs thawed, the cumulative pregnancy rate is about 95%. And for those women who froze after the age of 35, the cumulative live birth rate drops down to 50%. There's a low medical risk from the procedure of harvesting eggs in terms for ovarian stimulation, egg retrieval, because these are young, healthy women. The obstetric risk is due to women being pregnant at an older age. And there seems to be no increased risk of congenital anomalies to children born from cryopreserved oocytes. Although the data is limited for definite analysis. Shukran, thank you.
Thank you very much, Dr. Razak. I think we'll leave the questions to the end because otherwise the program will be taking too much of time. I think I must thank you for the discussion, quite an extensive discussion, I must say. And what I was impressed that you discussed male fertility and infertility to a great extent, which many gynecologists do not do. So I think this will come back in question time, inshallah. I think we'll have our next speaker, and our next speaker is Professor Mohsin Ibrahim. And Professor Mohsin did his undergraduate studies in Pakistan and Egypt. He did his PhD from Temple University in the United States. He's an emeritus professor in the School of Religion and Philosophy and Classics at KZN. He has written extensively on biomedical ethics and has presented at many local and international conferences. He will address us on the Islamic principles on on the Islamic principles when attending to an infertile couple, especially a Muslim couple, and what are the challenges that lie ahead? Professor Mohsin, please.
Alhamdulillah Rabbil Alameen wa salatu wa salamu ala ashrafil mursaleen Sayyidina wa Nabiyina Maulana Muhammad wa ala alihi wa sahbihi ajma'in wa ba'd. Assalamu alaikum to everyone. Wait, I'm just trying to share it. Yeah, okay. So basically my talk will be on infertility and assisted reproductive technologies, ART, the Muslim dilemma. Now the scope of presentation, the introduction, infertile prophets in the Quran, lay infertile Muslims, sorry, it's jumping that thing. Lay infertile Muslim strategy, infertility in the Quran, infertility and medical intervention, seeking treatment in light of Hadith, ART and infertility, the problem, ethical-legal concerns, third-party intervention, surrogacy, human cloning, and finally the conclusion. Now let us look at the humans expected to populate the world. For example, in the Quran, in Surah An-Nisa, Allah tells us, "O humankind, reverence your guardian Lord, who created you from a single person and created of like nature his mate, and from them twain scattered like seeds countless men and women." Islam, like other religions, encourages their followers to marry. For example, in the Sunnah or in the Hadith, we read, "Marry women who will love you and give birth to many children. I, Muhammad والسلام, shall take pride in the great number of my ummah nation." And this hadith is in Surah An-Nasai. The matrimonial union legitimizes the sexual act, which facilitates the sperm to fertilize the egg and hence procreation of the human race. But unfortunately, approximately 15% of couples in the world suffer from infertility. Now, when we go back to the Quran tells us, Allah subhanahu wa ta'ala tells us there were at least 2 prophets, who could not have children and they suffer from infertility. And the 2 prophets were Sayyidina Zakaria and Sayyidina Ibrahim alayhim salam, whose wives could not bear children, eventually died in their old age. Now, for example, in Surah Maryam, we read, Bismillahirrahmanirrahim, "This is a mention of the mercy of your Lord to his servant Zakaria when he called to his Lord, a private call, is the dua. He said, 'My Lord, indeed my bones have weakened, my head has filled with white, and never have I been in supplication to you, my Lord, unhappy, that is disappointed. And indeed I fear the successors after me, and my wife has been barren. So give me from yourself an heir who will inherit me and inherit from the family of Jacob, and make him, my Lord, pleasing to you.'" And as I say, this appears in Surah Maryam. Now, the inference from this is that his wife was barren, that his prophet Zachariah's wife was barren, alayhi salam, unable to bear children and beyond the age of bearing children. However, he still made the dua to Allah because he knew that nothing is impossible for him, that is for Allah subhanahu wa ta'ala. Now, let's go back to, come back to the mundane world that we live in, the infertile Muslim. How did they respond to infertility? Now, they resorted to, some of them, if their wife could not bear children, they always thought, the men always thought that it was the problem of the wife and not their problem, so they resorted to polygamy. But many a time they found that even after the second wife, third wife, and fourth wives, the wives do not fall pregnant. Anyway, some of them visited mazars and prayed or asked the wali to intercede for them, and sometimes it works, and the wives fell pregnant. And then some of them go to these people that give ta'weez, and then they will tell them that you must, what they have to do with the ta'weez and so on. And eventually, by Allah's permission, they fell pregnant. All right. Now, since legal adoption is not permissible, now there were others, in the Muslim community everywhere in the world, where infertile Muslims foster parented their siblings' children. And what happened quite miraculously after doing that, subsequently, their wives would fall pregnant. Now, there is an ayah in the Quran which we should all ponder over and think and reflect upon, and this speaks about infertility. He said, Bismillahirrahmanirrahim, to Allah belongs the kingdom of the heavens and the earth. He creates what he wills. He bestows female offspring upon whom he wills, and bestows male offspring upon whom he wills. Or he bestows both males and females, and he renders barren whom he wills. Verily, he is the all-knower and is able to do all things. That what have I underlined here? He renders barren whom he wills. Now, this is problematic here for Muslims, the dilemma the Muslims have. When their wives, or if they have been in marriage, as Dr. Danse told us, that within 1 year, no child, or the wife doesn't fall pregnant, then they begin to feel a bit worried about that. But then some of them, is it at that time, should we say that it is the will of Allah? Is it the will of Allah for us to be, not to have any children? Now, what I propose, is that we should look at that. Perhaps later on I may expand on that when he renders barren whom he wills. Then perhaps later on I'll touch on that. But what I want you to understand, is that we should view infertility as a inverted commas, in between inverted commas, as a disease, And even when Mr. Francois Ferreira and also Dr. Danse, when they presented the PowerPoints and so on, it became obvious, that there are certain interventions that can be done medically, and that can actually resolve the problem of infertility through drugs and lifestyle and so on, what Dr. Danse spoke about, and so on. All right. So this is what some of what Dr. Danse touched upon. Okay, we have male infertility, and perhaps all this can be corrected: azoospermia, reverse ejaculation, and so on. And female infertility, blockage of the fallopian tube, and ovulation induction, and so on. So all this can be rectified also, so it's sort of inverted commas disease. So we're trying to try and overcome that through whatever has been mentioned by the learned doctor and the drugs that have been mentioned by Mr. Francois Ferreira. Now, what is incorrectible? And this is where, we fall back to the ayah of the Quran. For example, if a female child is born without a uterus, so there's no way that this child, when it becomes mature and get married and so on, will be able to bear children, because there's no uterus whatsoever. Now we go back to the question of treatment, and in the hadith in Sunan Abi Dawud, it is mentioned the Bedouin Arabs came to the Prophet ﷺ and said, "O Messenger of Allah, should we treat ourselves?" He replied, "Yes, O servants of Allah, you must treat yourselves, for verily Allah has not created a disease without providing a cure for it, except for one disease." They asked him, "Which one?" He replied, "Old age." So this is an incentive for infertile couples to be able to go and to the gynecologist and and seek advice from the doctors and what can be done. So what I wish to point out here is that we must look at infertility as a disease. All right. So now we've known. I mean, Dr. Danse told us, and even the drugs that were told to us by Mr. François Pina is Ferreira, sorry, is that both, that it involves both male and female. So before, people always, especially in the Muslim and Indian community, the blame goes to the women. There's a problem with the woman; she cannot bear a child. It was never problem. It might be the problem with the male. So now, by when we made advancement in the medical field, then it is a must for every person or every couple, Muslim couple who cannot bear a child within the first year of marriage, then it should be a sort of concern for them, and they should try and rectify that medically, because that will be a form of treatment. Now, you see, as I mentioned, there are certain impediments to becoming pregnant. You may try all these drugs or whatever, but what happens is that it may not work eventually. When it may not work, so then we have to go to drastic measures of trying to conceive a child. Now, as a Muslim, should we make use of assisted reproductive technologies? Can Muslims therefore use that to be able to rectify the infertility or to treat infertility? Now, the problem with that is that attempts to manipulate pregnancy in the laboratory gives rise to a host of religio-ethical concerns, because conception becomes a medical event rather than an act of love. Now, if we speak about in vitro fertilization, during fertility treatment, only a single fertilized embryo selected for implantation. So now what happens to the other embryos? Dr. Danse mentioned about freezing them, okay? The fate of if you're going to discard them, they're tantamount to destroying human life, then they say that this is will be tantamount, because it's going to be, it's a potential human being already, all right? So then kept frozen, so to repeat the procedure, there's no problem. But posthumous implantation, the Dr. Danse mentioned that when we freeze the, when we freeze all this embryo or whatever, then what happens later on, if it is the question is, say, if, for example, they actually, for education, they could not fall pregnant the early part of their life. You mentioned one of these, and for career-wise, so they delayed bearing children. And one-third one was for persons who do not have any partner. So there is where the problem arises, because you cannot have a child as a Muslim woman if you are not married. That would not be allowed in Islamic, according to Sharia. All right. Now, the question of posthumous implantation. Now, there may be, some couples that get married, and then they actually freeze the embryo, and then say, after my husband dies, then I will have that, in vitro fertilization. I mean, the embryo to be implanted in the uterus, and then I can bear the child of my husband. But that would not be permissible according to Sharia, because death terminates the marital bond. So that would be not allowed. And donation to infertile couples. Now, if you have surplus embryo, now we say, okay, we're not going to destroy them. Then we're going to actually give them out, for people who are suffering from infertility. But again, that would not be allowed according to the Sharia. And then many a time in America, it has come to, we read a lot when I was doing my PhD at that time in 1980s, where adopted child marrying sibling and so on happened. Now, third-party intervention, child conceived through AID or egg donation is the fruit of the active element of a third party who has no moral and juridical bond or of conjugal procreation with a husband or wife of another person. So it is so the lineage of the child would be compromised. So there should be no third-party intervention. I'm talking about extreme cases here, when we're not talking about all that Dr. Dancy has been telling us, and Mr. Francois Ferreira has been telling us about the drugs that you're going to use when someone comes to you and say that the couple comes to you and say that we cannot bear children. I'm not talking about that. I'm talking the extreme cases where we now think of actually getting a third party involved in making us have a child. The married couple have a child. This is where I'm coming. I'm trying to think about and say whether this would be allowed or not. Okay, and here we come to the question of surrogacy. Now, surrogacy is a multiplicity of mothers. For example, Mrs. A is infertile. Miss B agrees to provide ova to be fertilized in vitro with semen from Mr. A. Embryos are transferred to Miss C, who agrees to carry the baby to term and hand it over to Mrs. A and her husband after birth. This is commercial surrogacy, could lead to enticing married women to resort to this reproductive option in order to relieve themselves of the agony of going through the pains of pregnancy and childbirth. It would therefore undermine the institution of family and family life. I remember when I was a student in America in the 1980s, our classmates, one of these females, they say, I will be skipping, varsity for 1 year. And we asked her why. She said, because I'm going to be a surrogate. And they paid at that time to be a surrogate was $10,000 US. It was a lot of money for them at that time. Today might be more, I'm not sure. But anyway, that's what they did. But as Muslims, what I want to impress upon, we cannot, no Muslim woman can act as a surrogate. And then no Muslim couple, let me tell you an example. For example, there was a young couple came to see me. It was some years ago. And told me that, what happens is that the doctor told us that the wife, is hostile to the sperm of the husband. So whenever the egg is fertilized by the husband's sperm, eventually there's miscarriage. So the doctor advised that you should actually get someone else to fertilize another person, like a AID, from someone who is not. So I told them that you cannot do that. There is where the Quranic verse comes, that one I quoted on the line, that if this happens, then it is the will of Allah, not for you to have a child. You're barren. So this is where we fall back and say that this is the destiny from Allah subhanahu wa ta'ala. It's just like the female who is born without a uterus. But anything besides that, which can be rectified, all Muslim couples who are suffering from infertility should be advised that they should seek medical attention to rectify infertility. Now I come to the question here is very extreme. This is human cloning. Children born in wedlock carry the genetic components of both parents, and this genetic combination gives them the identity. A human clone that involves a female having her clone without the genetic complement of her spouse would end up having no father. Consequently, 2, a human clone that involves a male having his own clone without the genetic complement of her spouse would end up having no mother. This form of asexual reproduction will undoubtedly contradict the divine pattern in the creation of humans, as is evident from the Quranic citation, "O mankind, we have created you from a male and female." You know, and I know this is extreme. I mean, there's around the world, there's a moratorium on human cloning. We all know that, but eventually they might start again. We don't know. They might try and do that. So as far as Islam is concerned, that would be not allowed, okay? The genetic replication through human cloning will negatively impact upon spousal and child-parent relationship and bring an end to the sanctity of the institution of the family. Human cloning will rob the child of her roots, ancestry, and undermine the laws of inheritance, which are based on consanguinity. So what happens here, what I want to say is that it may never happen that we'll be able to produce a human. We know about Dolly the sheep, you know, that was born and so on, but through the will of Allah, it may never happen because the laws of inheritance will be impeded if this happens. And Allah, and we know that the whatever has been revealed by Allah subhanahu wa ta'ala is true and will stand until Yawm al-Qiyamah. So this cannot happen, you know, illa mashallah, by the will of Allah subhanahu wa ta'ala. So the conclusion which I wish to draw here is, while acknowledging the fact that God in reality blesses some couples with children and some to remain infertile, resolving infertility through ART would not necessarily constitute interference with the divine will. All right, if you use the sperm of the husband and the sperm and the ova of the wife, there will be no problem. And also, all these medical treatments that have been put forth, or through the drugs by Mr. Francois Ferreira and Dr. Danse, and the question of lifestyle and so on, nothing would be taboo about that within, as far as the Sharia is concerned. It'd be perfectly in order. We're going to treat infertility as a disease, and therefore we're going to rectify it, inshallah ta'ala. Infertility, therefore, should be regarded as a disease that could be cured, so that the infertile couple may fulfill the religious imperative to populate the world. Now, as Muslims, you know, every Muslim couple, when they get married, all right, they have the aspiration to have a child. I mean, not only Muslim couple, but I'm talking specifically here about Muslim couple, because of the you know, the hadith of the Prophet ﷺ. You know, when there are three things that you know, will continue benefiting you after you depart from this world, and one of them is waladun yad'ulahu, that a child that will make dua for you. So that is why we find that there is a restlessness in infertile couple. They want to have a child, you know, Muslim couple especially, they want to have a child. And then also about the hadith of the Prophet ﷺ said that must populate the world. So that on Yawm al-Qiyamah, I will be proud to see so many of my followers. So ART has opened the doors to a host of possibilities in order to rectify infertility. However, Muslims ought to bear in mind that what may be possible may not necessarily be morally and religiously justified. Any assisted reproduction manipulation which involve a third party, both in the form of a sperm or egg donor or surrogacy, is strictly prohibited. Likewise, a human cloning as a means of rectifying infertility is also strongly censored according to the Sharia. So that is the end of my talk, and I'll be prepared to.
Jazakallah, Mohsin, beautiful lecture, and you covered quite a few angles to the topic. Unfortunately, there aren't many questions here. Most of the questions seem to be for Dr. Danse. I don't know why, but I think some questions will come up for you. Let's start off with Dr. Danse first, please. The first is, a doctor is asking you, Dr. Danse, that what's the average cost for any procedure, any assisted procedure, whether it's a procedure done privately or in the state hospital? Are state hospitals doing these procedures, the assisted ones, or is it only done in the private sector?
Okay, I think in Western Cape, we're very, very fortunate that the public sector, Tygerberg Hospital is offering a full range of infertility treatment, and Grooteskier Hospital as well. I'm aware that the Pretoria Academic is also offering state subsidized fertility treatment as well. The cost of in vitro fertilization cycle, which includes from consultation to the medication to egg retrieval, is between 55 to 70,000 rand. The average is around about 50. I think in Johannesburg and Pretoria might be a bit more. And any good IVF program involves embryo freezing as well, which means that if they did fall pregnant for the second time round, they don't need to go through the whole IVF cycle. If they were not successful the first time, the frozen embryos can be used for the second time. So the cost of embryo freezing is initial preparation about 10,000, about 9 to 10,000 rand per year, then about 3,000 rand per year thereafter. This also depends on the number of embryos that were actually frozen and the number of the devices that were used for actual freezing procedure. So IVF about 50 to 70,000 rand. Intrauterine insemination is probably between 3 to 5,000 rand. If it is a low dose cycle, which means only letrozole or clonopin citrate, is probably 3,000 rand. The minute we add gonadotrophins to it, it comes at between 5 to 7,000 rand. That is per insemination cycle.
Okay, thank you very much. I'm sure the experience is the same in KwaZulu-Natal and in Gauteng. But if there's any gynecologist on this webinar, you could unmute yourself or raise your hand and I will sort of allow you to speak on the topic. The second one is that Dr. Danse, in your presentation, you mentioned about the male factor in quite detail, and quite rightly so, because as you said, that the male is responsible for at least 30 to 40% of the time, and it's not only the female. And what we find in practice is that the male is very reluctant to come forward. It is more the female with her instinct of having children comes to the doctor. What's the experience in Cape Town? Do you have clinics where both males and females present, or do you just have females presenting to you?
No, I mean, you know, from my experience, or the patient that I consult for the first consultation, both of them, I think more than 90% males and females actually come. So for the first consultation, both actually come, which I think is very, very nice, because it's not a problem of the woman or the male, it is a problem actually both. So when we make the point, we insist that both come at the same time, and I think they appreciate it a lot. Number one. Number two is often there might be a reluctance on men to actually, you know, to produce a sperm sample, or they say, doctor, I'm fine. So we try to make it very, very easy. So we say that, you know, here's a container. You don't need to bring it yourself. Send your wife can bring it in. And that's how we do it. So very seldom there's the reluctance. But I think it's important for both couples to be seen, and I'm unfortunate that more than 90% of couples, both of them actually come at the same time.
Yeah. And as far as the male is concerned, are there clinics? I know in Durban more the urologist sees to them, but do the gynecologists see to them also?
In my practice and in our clinic that we share, I think most of the time we actually see them ourselves. The only time when the urologists get involved is when when there's borderline sperms and there's no female factor, just to exclude a varicocele. Now those ones that are those are clinical palpable, they probably have an issue, but often with the with the subclinical ones. So we send them to urologists just to make sure is there any reversible factor from their point of view or not. And I think the men appreciate it as well, to just make sure that they have seen somebody as well. But in most cases, we treat them. If it is low sperm count, we treat whatever we need to do. But the urologist, just for a second opinion.
Excellent. We have another question. Does a low carb diet or a ketogenic diet help patients with polycystic ovarian syndrome?
I cannot answer that. What I do know is, when it comes to weight loss, there's so many different diets. But what I do know that a low carbohydrate and a more protein-based diet is probably actually way to go. But I think it is consistency. Often we find that women say that, doctor, I do not eat a lot, but if you take down the history, often they actually skip meals, they don't have breakfast, and often if they're working, they don't take food from home to work, they actually buy from outside. So in my view is if women eat healthy, if you have cooked meals, if you eat healthy, if you take food from leftover food from home to your work, I think these women will they're probably on the right path. But low carbohydrate diets and more protein is actually correct.
Okay. A doctor wants you to comment on inflammatory polycystic ovarian syndrome, somebody who's got an inflammatory disease. Is there such a thing, by the way?
No, there is. I can't actually recall. I have to read about it last week as well. When I was preparing for it, there's an inflammatory component as well. I need to, but I can't actually remember what it actually was about. But no.
Okay, we go to the next one.
There's some. I did actually read about it, but I can't actually remember.
Okay. All right. Is there any role for GP1 agonists for weight loss? The GPL1 agonists, like the sitagliptins, for example. I suppose the answer is neither here nor there when it comes to
I haven't got any
Yes.
experience. What might work for one person might not actually work for somebody else.
Okay, no, that's understandable. What about the hormone tyrosine? The thyroxine hormone, does it have any benefit for patients who suffer from PCOS?
Is he talking about
As a supplementation?
thyroxine?
I think Francois mentioned it also.
When it comes to sperms get stressed also from I'm trying to get to the right word, from the oxidative stresses.
Yes.
Now, oxidative stress can cause sperm abnormalities as well. So things that they help with antioxidants would be vitamin C, vitamin E, the omega-3 and 6, selenium, and some of the products which Francois actually mentioned. And those antioxidants do actually have a role to play.
Okay, the next one is the drug clomiphene is commonly used by general practitioners in the hope that the lady in front of them would get pregnant after 2 or 3 cycles, knowing fully well that the woman has not been investigated. Do you think is this the correct procedure?
Yes, I think if it is if they are I think this is more to do with, with maybe not fully investigate, but if it is a young couple, periods are regular, there is no risk factors for any tubal disease in terms of having had any operation before, no appendix operation, no history of PID, and it's a short infertility. And that's why we insist, to do a sperm test, because it's so easy to actually examine the man. He needn't be for him, it's very easy to examine. So if the sperms are normal, if there's nothing wrong with the woman in terms of very basic investigation, I don't think there's anything wrong in doing, in giving a clomiphene citrate for 3 or 4 cycles, as long as and as long as ovulation has been documented. Now, normally when we do it, we do cycle tracking. They would have an ultrasound done on day 12 to see is there a dominant follicle or not, and when are they more likely to actually ovulate. So you can, when ultrasound is very accurate, it can tell you exactly those women can ovulate between these following days. If they come on day 12 to do ultrasound and the follicle is not yet mature, they need to come back a few days later to check on it is mature. So with ultrasound, it gives you accurate information. But I think in a general practice setup, people with normal cycles, it's unexplained. And I don't think there's any harm done, by giving the clomiphene citrate, and after 3 or 4 cycles, they did not fall actually pregnant. And I'm sure a lot of general practice are doing it, and I'm sure there's a large number that do fall actually pregnant as well.
Yes.
But I think you cannot.
Any
I wouldn't
particular side
recommend
effect?
more than 4 cycles.
Sorry, any particular side effects from clomiphene that doctors should be mindful of?
Okay, it's if it is somebody with PCO, with polycystic ovarian syndrome, I mean they can actually over respond. In other words, in terms of multiple pregnancy. Number one. Number two is the clomiphene citrate has a adverse effect on the endometrial lining. In other words, the endometrium. It can make the endometrium thin. In other words, it thins the endometrium instead of making it thick. And this is where letrozole has an advantage. It doesn't affect the endometrial lining. So if it is given over a short period, 3 or 4 cycles, I don't see any harm. But the risk of clomiphene citrate is in fact multiple pregnancy, and some women can just over respond.
Okay. All right, Jazakallah, I think your questions are over. Most of the questions were for you. Jazakallah, Dr. Razak Danse, you've done very well, mashallah. We've learned a lot. And I think a lot of the messages that you've sent through your slides and in the question and answer session is really helpful to most of us. Jazakallah. Professor Mohsin, we've got a few questions for you. You're not going to just go away home. Oh, you are home, by the way. Okay. You can hear me, Mohsin?
Yeah, I can.
Yeah. Okay, when you mention in assisted fertilization, one sperm fertilizes an egg and you form an embryo and the rest of the eggs are destroyed, doesn't that happen in normal fertilization also?
We're talking about here is when you take you see what happens is that you have to fertilize a number of ova first, because we don't know which one will actually be viable for transfer into the uterus and so on. So that's what I'm talking about. So if you have a surplus of that, and then the question that was raised, I mean, among the, in this, what you call that, Islamic fiqh academies around the world, was that if it is discarded, then what happens? But again, they resolved that. They say that if it's discarded, then there's nothing wrong, because the roe appears only in the 4th month of pregnancy. So there's nothing wrong if you have to discard the fertilized ova, after you find out that that one of the ova is, or two, whatever, is viable for implantation, and the woman will be able to give birth to a healthy child.
Okay, Jazakallah for that. The second one is that if a woman is unable to give birth, is unable to conceive, if she's been for a checkup, she's unable to conceive, she's been told by 2 Muslim gynecologists she's unable to conceive, and the man is fertile, is it okay for him to remarry? If he takes on a second wife, will that be kosher?
If
As
it
it
is
happens
for him to
quite often.
remarry, based on what?
Means if a couple is there, they're infertile, unable to conceive a child, and if the woman gives consent to the man,
Yeah.
give consent or does not give consent, is the man allowed to take on a second wife with the intention of having children?
Yeah, but then her problem won't be solved. Her problem won't be solved. But then if she agrees, that that you can, because she'll be the second mother anyway. She'll be,
Yeah.
because she's married to the husband. So, it'd be a good thing. There's nothing wrong in that.
Why
But
I'm
first must
asking you this
establish,
in
must
particular
first establish
because
that there's nothing wrong with the husband, because it may happen that she gets married to another person, and again the woman will not be able to bear a child. So first we establish that, and then if it says that you are the problem and you may not be able to, but if she has, then we can try the ART. I don't know, Dr. Dansi perhaps be able to, if we can, I don't know what it means that you cannot, if you cannot give birth. I'm not a medical person. Perhaps the doctor be able to come in here and explain, whether if it was in vitro fertilization, even then she won't be able to give birth. I'm not sure.
if she's got complete ovarian failure, Dr. Razak Danse, do you want to come in here?
That's okay, we
Where
can talk, yeah.
where you would sort of say categorically that you would not be able to give birth to a child.
Yes, if she has complete ovarian failure, yes. Yeah.
Yes. Okay, so because there are cases in the African Muslim community, and it may be in our community also, where women are very ill, for example, very old, or they're unable to conceive a child because of ovarian failure. She then tells her husband, it's a very honorable wife and a very pleasant wife. She tells her husband, you can take on another wife with the intention of having a child. And then she is fulfilled in the sense that they become now a family. She becomes like the second mother.
Yeah, no, there's nothing wrong with that.
There's
Yeah.
nothing wrong with that.
No.
Okay, hold
Of
on.
course. Because it's done legally. It's done legally. It's not using anyone as a surrogate here. We're getting married.
No.
Yeah, it's
Legal nikah. A nikah, and maybe with the consent or without the consent. That's another debatable issue. I don't know whether you want to answer that or not.
that's another debate, though.
That's another debate.
Yeah,
The last question is, you mentioned that infertility is a disease. You think it's a disease or a challenge?
No, I would look at it as a disease. If you're going to take the drugs and try to overcome that, that we've been having, like Dr. Dan said, even a lifestyle, the change of lifestyle and so on. So that's why I say between inverted commas, then between inverted commas,
Okay.
it's a disease. Yeah.
I wish there were more questions for you, Mohsin, but I think because they saw your title of Professor Mohsin, they all studied and they wouldn't want to ask you any questions. But Jazakallah to both your
There's
speakers.
a question there. There's a question there for me. There's a question for me there.
Is there a question for you?
In the chat.
I don't see it.
You say,
Here you are. There's one here. Sorry. How would you manage infertility in a discordant couple?
No, there's another one. It says, I think Professor Ibrahim has not answered the question posed. It's a simple question. Is infertility grounds for divorce? But then I wasn't asked that question.
Yes, no, I didn't ask you that question,
Yeah,
but
now,
maybe it's a question you can tackle also.
yeah, if you want me to answer that question, is it grounds for divorce? No, but what we have to understand, is that through the wisdom of Allah subhanahu wa ta'ala, He has allowed man to have more than one wife. All right. So I think that it would be not right for us to do that, to divorce the wife because she cannot bear a child. I would actually go and say, okay, let's have a second wife and keep the first wife also, and have a second wife, and hopefully the second wife would be able to have a child with the second wife. But I don't think it would be if you go to the Molana, you can buy what do you call that fatwa today? They call it you can go to anyone and get different fatwas. Then perhaps some Molanas will tell you that he's ground for divorce. But I think that we should not use it as a ground for divorce, but actually be magnanimous. Your magnanimity is important here, that you keep the wife, and then because that for her not to be able to bear a child is from Allah subhanahu wa ta'ala. So why don't we give her shelter also, and within our means, and have another wife.
Yes, no doubt about it. I see there was one question which I missed from Dr. Timol. He asked, are obese women more likely to have PCOS than normal or lean women? It's for Dr. Danse. Dr. Danse? About obese women and lean women.
Okay.
Everyone wants a lean wife, it seems like.
Okay. When it comes to PCO, as I said from the beginning, there are some women on ultrasound, they got PCO on ultrasound, they haven't got the syndrome. In other words, when you do the ultrasound, they got regular cycles, but they got PCO morphology on ultrasound. So when these women put on weight, that is when the problem actually starts. So it's a weight that triggers off the insulin resistance, starting to skip the periods, etc. So I think a lot of women with PCO, probably more than 40% of them are actually obese as well. But then you have the lean PCO woman. Now that is a different category. They are a bit more difficult to actually treat. So the women that are obese PCO, if they lose weight, a lot of they will ovulate spontaneously, the chance of pregnancy improves. But there's a group of lean women, PCO, and they are a bit more actually difficult because you can't ask them to lose more weight. They're not, but their metabolism or their PCO is on a different basis. So they are a lot more difficult to actually treat. But obesity has a big role to play in it. So often women can't understand, my periods are regular, they were always regular, how come I got PCO now? But once you put on weight, that triggers off the whole thing about insulin resistance, etc.
Okay, I think that was a very important question and a very good explanation. I think we've come to the end of this program. It's already 20:09. It leaves me to thank all those that have attended this evening's program. CPD certificates will be mailed to you in a few days. You'll also get the recording. You will be sent the link. The organizing committee, the staff at the office, the speakers and the attendees for making this possible. We thank you. And last but not least, Dr. Famida Sheikh, the academic researcher at UKZN. She's been at the background hosting this webinar. We'd like to thank her for her expertise. I would now ask Dr. Professor Mohsin Ibrahim to make the final dua, please. Jazakallah.
اللهم آمين. ربنا تقبل دعاء إنك أنت السميع العليم وتب علينا إنك أنت التواب الرحيم. ربنا ظلمنا أنفسنا ولم تغفر لنا وترحمنا لنكونن من الخاسرين. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. اللهم افتح لنا بالخير واختم لنا بالخير واجعل عواقب أمورنا بالخير بيدك الخير إنك على كل شيء قدير. إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما. اللهم صل على سيدنا محمد وعلى آل سيدنا محمد وبارك وسلم دعواهم سبحانك اللهم وتياتهم فيها سلام وآخر دعوانا الحمد لله رب العالمين والسلام عليكم.
Jazakallah to everybody. Assalamu alaikum wa rahmatullahi wa barakatuh.